Let's talk about superior mesenteric artery syndrome, SMAS. Before we talk about any disease process, we have to talk about anatomy. So here's your upper GI tract, your esophagus, which is the pump to get food from your throat into your stomach. The stomach is a reservoir for food. You've got the duodenum here. The duodenum is the first part of the small intestine, and what's not being shown is the rest of the small intestine and the large intestine. Now let's talk about the vasculature. Below the diaphragm, where the abdomen is, you've got three major arteries coming off the aorta. The first major artery is the celiac artery. The celiac artery gives blood supply to your stomach, your liver, and your spleen. The second major artery is your SMA, the superior mesenteric artery. And if you have a superior, you must have an inferior mesenteric artery. The IMA, or the inferior mesenteric artery, gives blood supply to your large intestine, your colon and your rectum. Now let's focus on the SMA. The superior mesenteric artery gives blood supply to your pancreas and your small intestine. If there's a compression of the duodenum, the third part of the duodenum, which passes between the SMA and the aorta, if you have a compression there, with the symptoms that would go with that compression, then you may have what's called superior mesenteric artery syndrome. So first of all, why does that compression develop? The majority of patients get this compression because of profound or rapid weight loss. A lot of our patients have MALS, median arcuate ligament syndrome, compression of this area, this nerve usually, or artery. A lot of patients have compression of this area where you have the celiac artery and the celiac ganglion, which leads to weight loss, which can then secondarily lead to SMA syndrome. Some patients have a different form of connective tissue, which is either the primary or an additional reason for why patients may develop SMA syndrome. Now, in contrast to MALS, which is a pinching of the artery and nerve, SMAS is a pinching of the intestine by the artery. The artery is the culprit here. Your SMA is normal, but the fat pad between the SMA and the aorta typically has shrunk, or there's an elongation, which leads to compression of the duodenum. So what are the symptoms of SMAS? So in contrast to MALS, most patients with SMAS develop pain a little bit later after they eat, potentially hours instead of minutes afterwards. The pain in comparison to MALS is lower down. So if MALS pain is up high, SMAS is closer down to the belly button. The pain is more crampy in nature, and really unique to SMAS and different from MALS is that it does matter what you eat. Most patients will develop pain mainly from fibrous foods or dense, chewy, dry foods. So things like raw vegetables, fruits with skin, salads, which are all fibrous, or chewy foods like chicken breast, steak, bread. In contrast to things like liquids and pureed foods, smoothies, yogurt, and even processed foods, things like mashed potatoes, mushy foods tend to go easier than the dense, chewy, fibrous foods. So we always ask our patients to keep a food diary to see if they notice any correlations. As far as diagnosis goes, so there's two tests that we always get to see if a patient has SMAS. One of them is an upper GI barium swallow. So you drink contrast. It basically gives us a black and white version of this model here. You might see either a complete stop of fluid right here, or what they call a to and fro motion, kind of like a pendulum, where the liquid's trying to make its way through. Now, it doesn't always catch SMAS. If you're having issues with liquids, that's pretty advanced disease, but some patients are having issues with just food. In addition to getting an upper GI, we also get what's called a CT scan or a CAT scan of the abdomen and pelvis. When we get a CT scan, we're looking to see if there's compression and if there's a narrowing between the aorta and the SMA. So we want an actual measurement of that angle and distance. Greater than 28 degrees and a distance greater than 12 millimeters is considered normal. 18 to 28 degrees and 8 to 12 millimeters in distance are gray zone, and anybody with an angle less than 18 degrees or a distance less than 8 millimeters, there's going to be a high suspicion that patient has SMAS. In addition to getting these studies, all patients have to get an upper endoscopy and a gastric emptying scan. Why do we get a gastric emptying scan? Contrary to what many people think, most patients who have SMAS actually have normal emptying of their stomach. But if you have abnormal emptying of your stomach, the symptoms of that mimic exactly the symptoms of SMAS, and it does complicate things and changes things. So we have to see if there's issues with emptying of your stomach as well as SMAS, or is it just SMAS that we're dealing with. Let's talk about the operations. So there's 3 main operations that people do for SMAS. The first one and the most common that's being done around the country and probably around the world is the duodenojejunostomy, a DDJ. In this operation, we're bringing up a loop of the intestine and connecting it here to bypass the area of compression. The problem with this operation is twofold. Number one, you still have a compression of the duodenum, which can lead to pain and dysmotility. Secondly, that loop anastomosis, the loop bypass that you've created, has 2 paths for food. And sometimes food or liquids will go backwards to what's called the afferent limb. And if that happens often or builds up, you can get what's called afferent loop syndrome, which needs to be addressed. Another operation that people do for SMAS is what's called the strong procedure. In the strong procedure, you're moving the duodenum away from the SMA. You're essentially taking down what's called the ligament of Treitz. The issue with this one is that it reverts back to its original anatomy very often. Now, of the patients that I've done a DDJ with or without a strong procedure, half those patients are still not doing well, which brought me to a more complex but better operation for SMAS called the duodenal derotation. So the duodenal derotation, or the intestinal derotation, popularized by Domingo Alvear, is essentially moving all of the small intestine all the way from your duodenum down to your colon, away from the SMA, so it never has a chance to go back. Now, in addition to doing that, I also do what's called a duodenoduodenostomy. I connect the second and fourth portion of your duodenum together. Number one, this makes it almost impossible for the duodenum to ever go back to where it was. And number two, it opens up this area, which even if it's moved away, this area often is still narrowed or strictured or kinked and twisted. So we do what's called the duodenal derotation. I do a duodenoduodenostomy, which is an anastomosis. And because your right colon flips up to your left side, we take out the appendix so we don't confuse appendicitis for a complication from this. The recovery from SMAS is very intense. It can be anywhere from 4 weeks to 4 months. Now, even though I do these operations robotically, because of the new anatomy, the GI tract tends to shut down. And through experience, I've seen that a good portion of patients will need a GJ tube, a tube that goes into their stomach to drain the stomach. Otherwise, they'll be vomiting bile for days or weeks on end. In addition to putting in a GJ tube to decompress your stomach and to feed the intestine, we also have you go home or leave the hospital with IV nutrition through a PICC line called TPN. The reason we do this, that anastomosis is a high-risk anastomosis. Most of our patients come in at least a little bit malnourished, and we can't afford anybody to have any issues with that anastomosis. So immediately after surgery, you want to get your nourishment back up, which is why all patients go home with IV nutrition. The majority of our patients come from out of state. Most patients are in the hospital for about a week, and we ask that most patients stay around LA for about 2 weeks. Before you go back to your home state, we see patients in the office at 1 or 2 weeks, and then we do long-term follow-ups afterwards. We see our patients at 6 weeks, 12 weeks, which is 3 months, 6 months, 9 months, 1 year, and once a year after that. We're gonna be friends for the rest of your life. If you're not doing well, we want to know. I wanna know if you're having issues either with that operation or other GI issues that I can help you fix. Now, just to close out, I do about 20 of these operations per year. In our first 30 patients, of which 22 to 23 had a duodenal derotation, 85% of those patients are doing well long-term. In contrast, the 50% that are doing well with the DDJ, with or without the strong procedure. And it's for that reason that the only operation that I offer for SMAS is the duodenal derotation with the duodenoduodenostomy.